Pseudo mean?
Fake.
False, fake. Okay, decreased production of the platelets may be inherited, thrombocytopenia, marrow failure, pancytopenia, B12 deficiencies, drugs, alcohol, sometimes sulfur containing medicines, antibiotics, thiazides, interferons, A megakaryocyte thrombocytopenia because of myelodysplasia, bone marrow problem, or immune related aplastic anemia. So there will be a decreased production. Malignancies, myelodysplasias, and congenital Wiskott-Aldrich syndrome or Fanconi syndrome, or paroxysmal nocturnal hemoglobinuria. So inherited thrombocytopenia because of the congenital aplastic anemias, Fanconi syndromes. So here is the platelet, giant platelets, macroplatelets. They come and clump together. Platelets will be there. They will clump in one place. So when they are clumped in one place, they will be not available for to cure the bleeding or to control the bleeding. So there will be thrombocytopenia and there will be high chances of the bleeding. Here is the Bayern-Soller syndrome, BS syndrome, macrothrombocytopes, and then here is the Wiskott-Aldrich syndrome, microthrombocytes. In both situations, there will be decreased production. Increased destruction, immune type. The common one is the idiopathic thrombocytopenic purpura, ITP. Drug induced, many of the time, interferons, sometimes antihypertensives, sometimes antibiotics, post transfusion. All these they lead to immune or immune sometime as well. Sometimes non-immune, DIC, disseminated intravascular coagulation, preeclampsia in the female. All these situations they lead to thrombocytopenia. And the situation is increased thrombocytopenia, increased destruction. Usually it is said it is benign in the 5%, but in 75% of the cases it occurs, thrombocytopenia accounts for about 75% of the cases of the thrombocytopenia. Asymptomatic, but particularly in female they are preeclamptic. You know preeclampsia, maybe in the gynae you see. Hypertension before and during the late phase of the pregnancy, and this situation is preeclampsia, and later on it leads to eclampsia, where eclampsia there are fits and serious situation. So there is an increased incidence in pregnancy of idiopathic thrombocytopenic purpura. As the name shows, idiopathic, sure cause is not known, but these are some of the major causes. Sequestration, immune destruction. We discussed, if you remember, we discussed this in the last year when we were discussing the host defense block, complement systems. We discussed some of the diseases, paroxysmal nocturnal hemoglobinuria and all. Intravascular coagulation, DIC, disseminated intravascular coagulation, particularly occur in this type of the preeclampsia even. When there are small clumps of the platelets are there all over the body. When there are small clumps of the platelets in all over the body, what will happen? The number of the platelet will be reduced. The number of the platelets will be reduced, and then there will be a high chance of the bleeding. I'm sure when you will go in next years, you will see the treatment. The funny story is that the treatment for this, what I remember, is the heparin. So there is platelet reduction, and there are clumps, but in order to dislodge those clumps, you need an anticoagulator. So it's a very sensitive situation, very sensitive situation. Brain work, is required. If you increase heparin, there is a chance of bleeding. There is a chance of bleeding. Very technical things are there. Sometimes medicine gives you a real challenge. You are treating disease with a poison. So a disease is there and a poison is there. Sometimes disease may kill the person. Sometimes the treatment, which is a poison, may kill the person. So it gives you a very this is just an analogy. Or damage of the enzymes by the bacterial enzymes. So this will lead to increased platelet consumption. Now immune platelet destruction, autoimmune disease, childhood and Idiopathic thrombocytopenia sometime occur in childhood, sometime in adult. Drug-induced heparin-quinones, immune complex infections, and then sometime the platelet antigen are inherited from both mother and father, so post-transfusion purpura and neonatal purpuras. Post-transfusion purpura is very common, sometime caused by the re-exposure to the foreign platelet antigen. So those people, they are on frequent transfusion, they develop this. Almost all cases in multiparous women, human platelet antigen 1A, formerly platelet A1, antigen most commonly involved and present in 98% of the population. Antibodies caused by the destruction of the patient on platelet by uncertain mechanism. And possibly due to coating of the patient platelet by donor platelet microparticles, and it is present sudden onset of severe thrombocytopenia. So, sudden onset of severe thrombocytopenia. So, consider the diagnosis. Whenever there is a sudden, severe, unexplained drop in the platelet count in a hospitalized patient, just keep this in your mind that it may be a post-transfusion purpura. Infection causes sometimes the destruction in the platelets, and childhood idiopathic thrombocytopenic purpura, bacterial sepsis, hepatitis, activation of the coagulation cascade because of the DIC, viral infections. We have so many viral infections nowadays. We have very recently, this dengue fever, which is coming from a mosquito, like malarial parasite, similar like that, and it leads to destruction of the platelet, and then the people, they die just because of the bleeding. Although the treatment is very simple, but because of too much mass area is involved, so it is sometimes uncontrollable. It's uncontrollable.
Usually in all the previous disorders, the problem is global or local from endothelium.
For endothelium,
Yeah.
global. If there is a problem in the endothelium, yeah. Drug-induced immunocytopenia, quinone, very common. Heparin platelet complex will form, we saw earlier. Huh? So these are the drugs of the list which can cause thrombocytopenia. Now, idiopathic thrombocytopenia. In children common, in adult more common. Most less than 10 years of the age may follow viral infection, vaccination, peak incidence in fall and winter, and 50% some treatment, but 75% remission occur within 6 months. Adult, no prodrome. Let's say the issue. You don't see anything before the infection, before this situation occur. In children, some people might have some viral infection. So when there is an infection, you keep this in your mind that there may be chance of the thrombocytopenia. Chronic recurrence is common, spontaneous remission rate is 5%. Treatment is, so this is how it occurs. Huh? For example, see here, we discussed this earlier in immunology block. Virus is there, immunoglobulin, then adsorption of antigen-antibody complex, C3 is activated, complement system is activated, complement fixation, and then this if you give a steroid, it will inactivate this, otherwise it will go and lead to lysis or phagocytosis. This is childhood. In childhood you have virus. So when you have viruses there may be fever, sore throat, like viral features will be there, prodrome will be there. So somebody comes to you with a fever, chills, sore throat. So you will keep this in your mind that this boy might have developed, maybe having a chance of thrombocytopenia. Clear? Gentlemen? What is our topic? Yes, you. What is the topic? Huh? But here in the down, what is the difference? In down, you would not see any prodrome virus. Platelet is there, platelets is there, antiplatelet antibodies are formed due to any reason, we don't know. And then the rest of the mechanism is same. Steroid helps here. Steroid helps here. Tamam? Steroid helps here. That's why in adulthood suddenly appears and then leads to complications if not treated. Prevalence is 1:1 to 10 in 100,000, slightly more common in women. Peak incidence at about age 60, 40% have associated disorders. Sometimes autoimmune diseases are associated like SLE, antiphospholipid syndrome, chronic lymphocytic leukemias. So these are the associated symptoms which are there. ITP is relatively benign, but prospective studies in ATP said that it is technically not asymptomatic people, but when there is too much decrease in the level of the platelet, then the problems occur. Splenectomy helps. If you remove the spleen, then the available platelets might help. Why the removal of the spleen will be helpful? You last one, gentlemen. Why the removal of the spleen will be helpful? You last one. Yes. What is the topic, by the way?
I just came back.
Oh, you came, but what is the topic, by the way? You know spleen, where is the spleen?
Spleen?
Spleen.
It's here.
Huh?
Next to the liver and the stomach.
Next to the liver here.
Do you want me to come and show you the...
No, I just want you to let us know from there.
Yeah, I know the location of the spleen.
Oh, what is the location? Tell us the location.
How do you want me to explain the location? I told you that...
You are a third-year student, you should know how to explain anatomical location. You are a third-year student, you should know how to explain the anatomical. I can explain this to you for anatomical location, and you will understand in a second. I mean, you know the quadrant, isn't it? So you should say, which quadrant is this? There is no question to be furious. I am just asking, you are a third-year student, tomorrow you will go and treat the patient. If you don't know, tell us you don't know. Because what I'm observing, you are not attentive. And this is an important topic. But you are not attentive. Anyway. So this is the situation. So sometimes spleen, and many of the time the spleen removal of the spleen helps. Because whatever the platelets are available, if they go and destroy there, then it will create more serious situation. So removal of the spleen helps. So platelet reactive autoantibodies present in most of the cases, often specific for platelet membrane glycoproteins, and antibody platelet are cleared by the macrophage, which discussed earlier this one. Clinical features, very common. Petechiae, purpura, bleeding, so many common things are there. The more low level of the platelets, the more severe will be the symptoms. And sometimes very serious bleeding, life-threatening situation. Although the mortality is less than 5%, because bleeding is one of the such situation, whenever it starts, it is noticeable. It is noticeable. You got this point? When there is a bleeding, it is noticeable. So when it is noticeable, so people take care of this. That's why the chances of the mortality is less. But if bleeding occur in some situation, in some areas where it is not controllable, maybe in the brain, so then you cannot control it. So that's why it is dangerous as well. It is dangerous as well. So how you will confirm this? You can do the serum antiplatelet antibodies, although sensitivity is not good, and test for specific antiplatelet glycoproteins, which is more specific but negative in 10 to 30% of the cases. How you will treat it? In children, platelet 20 to 30,000, no bleeding, no treatment is required. But if there is 30 to 70 it occurs within 3 months. If the platelets are less than 10,000 or 20,000, then there are chance of the significant bleeding, so you can treat it. So if you give IV glucocorticoids, IV steroids, how it will help the patient? Yes, you have any idea? If you give him this one in front of you, behind you, you have any idea? If you give him steroid, how it will help the patient? near to the Ghaznavi. Yes. If you give him steroid, how it will help the patient? Yes.
It's anti-inflammatory
Then how it will help in this situation?
because it's caused by virus.
Okay.
Then provided the anti-inflammatory,
Okay.
then the reaction to
The doctor is going to stop the psychosis.
Here. This is the level which it will block. So when it will block, this will not be there. So chances are there that it may be.
Can be used for long term.
Sorry? Have its own problem. Big problems. Huge problems. So, and then immune reduction as well. So single dose you can give them and then you can repeat it the doses again. Splenectomy reserved for chronic idiopathic thrombocytopenic purpura and for the refractory cases, pre-immunized with pneumococcal and influenza infection and all these things is very important. Adult, newly diagnosed adult, platelet less than 20 to 30,000, dangerous chances. Active bleeding for high bleeding risk more than 50,000, first line treatment is glucocorticoid. Then intravenous immunoglobulins, very expensive, specialized centers are required, 10 to 30% failure chances. Then anti-RH globulin or splenectomy. Hospitalization is not required, but sometime when you need this this therapy, immunoglobulin IV therapy, then you might need hospitalization. Technically not required. Day care, give injection and go home. But chances of failure are high. And point number 2 is, in many countries, it is very expensive, immunoglobulins, very expensive. So, glucocorticoid therapy, slow platelet destruction, reduce autoimmune productions, prednisolone 1 to 2 milligram per kg single dose, and begin slow after 2 to 4, and then taper it after 2 to 4 weeks. Alternative therapy if no response within 3 to 4 weeks, and about 2/3 of the patient response. Earlier days, what I have seen in my practice, earlier they glucocorticoid, they respond. You give them glucocorticoid and they respond quickly. But later on, when there are recurrence occur because of any reason or because of any infection, sometimes it don't work even. Then you go out to the progressive state. High response rate, outpatient therapy is good. I mean, you can do it in good. Disadvantage, steroid toxicity. By itself, it creates too much problem. Splenectomy is sustained remission for 2 to 3, 2/3 of the patients. Almost all responses occur within 7 to 10 days after the splenectomy. Operative mortality is not that much. It is less than 1%. So you can easily remove it. But even then, anesthetic problems are there. Severe intra or post-operative hemorrhage is rare. Laparoscopic splenectomy is usually very common and preferable, though they are expert in it. High sustained response cure rate, and disadvantage is that operative risk. Although technically operative risk is not that much, but you don't know. Sometime post-operative sepsis, and again it is not that much common, 1 in 15,000. If you are doing in a good, clean, well-controlled hospital, so chances are less. And when we do the splenectomy, when steroid therapy is not responsive or relapse has occurred because of the steroid therapy, so then we can do the splenectomy. Intravenous immunoglobulin therapy, yes, a slow mechanism of action, but slow the platelet consumption by inhibiting the FC receptors, block it. I don't know how many of you know FC receptor, but anyway, complement system. We discussed this last time, complement system. Disadvantage is rapid acting. Advantage is rapid acting, low toxicity, but disadvantage is high cost, short duration, and high relapse. And it is given when there is a life-threatening situation. So immunoglobulins are good, quickly occur. If there is a life-threatening bleeding, you can give it, but failure chances are higher. failure chances are there. Bone marrow is very good. If you can do that bone marrow transplant in young age, a good replacement, good treatment. But in old age, for bone marrow, the chances are not good. So only we left with the steroid, splenectomy, and immunoglobulins. And then very quick follow-up is required. Very quick follow-up is required. For IV immunoglobulin, this is the only disadvantage that it is many of the time it is, one is failure rate is little bit higher, another is expensive. Otherwise it's a very good therapy. So you don't have the chance, we should take chance. If you don't take chance, what we will do? Next option, we don't have any other next option. Clear, guys? So thank you very much.
Thank you.